Now here's a very interesting case of a patient with a posterior polar cataract. As you can see, the patient has a central classic posterior polar cataract with a bullseye appearance. In this case, you can see we've completed the rhexis and have achieved a nice localized oval capsular rhexis. The next step, as you know, which we would normally perform in a patient with a polar cataract, is the hydrodelineation. I'd like you to pay close attention whilst we perform the hydrodelineation. As I inject the fluid, notice the opening in the posterior capsule. Unsure of the opening, I inject again and I notice further splaying open of the posterior capsule. It is clearly obvious that I have a central opening in the posterior capsule. So how do we proceed from here? Some viscoelastic is introduced into the anterior chamber. I go with my slow motion phaco, which is I reduce the flow rate and I reduce the bottle height, and I proceed to try and aspirate the nucleus. Being very soft, I find it quite difficult to hold on to it. Finally, I'm able to hold on to the central endonucleus and piecemeal bring it up and aspirate it. Having completed the aspiration of the nucleus, I now attempt to hold on to the epinucleus, and having held on to it, my aim is to draw it towards the center and try and aspirate it. My aim is going to be that at all points I prevent any part of the epinucleus dropping down into the posterior segment via the PCR. Following the aspiration of a small part of the inferior epinucleus, I now use the Sinskey hook and draw out the subincisional epinucleus out of the capsular bag prior to aspirating it. With extreme care and caution, notice how I brought the inferior epinucleus out into the pupillary safe zone, and I'm trying to hold on to it and aspirate it, one, without letting it drop down into the posterior segment, and trying my best to ensure that I do not create any vitreous disturbance whilst doing so. Having completed the aspiration of some part of the epinucleus, I now perform a viscofluid exchange with the dispersive viscoelastic to keep the vitreous away. The rest of the epinucleus is now subsequently aspirated. Following the completion of the removal of the epinucleus, once more I perform a viscofluid exchange using a dispersive viscoelastic prior to bringing the phacoprobe out of the eye. And I'd like to notice that as I bring the phacoprobe out of the eye, the PCR increases in size. So at this point, I can see all the residual cortex, a large oval rent, and no residual fragments in the anterior chamber. We now proceed with the triamcinolone-assisted anterior vitrectomy. Having delineated the disturbed vitreous, I first plan to cut the vitreous that has prolapsed outside the wound, as you can see here, after which the irrigation is introduced into the eye held towards the angle. The cutter is then introduced into the anterior chamber, and then we start to cut the vitreous. Note how we cut the vitreous first within the wound, then in the area of the anterior chamber, the area of the other side port where it might have prolapsed, and finally the vitreous in the pupillary plane, and then the vitreous in the area of the PCR. Having cleared the disturbed vitreous, I then go in the IA cut mode of the vitrectomy, hold on to the cortex, draw it to the center, and aspirate it. The removal of the cortex using the IA cut mode of the vitrectomy is now being demonstrated in this part of the video. The irrigation still maintains counter pressure and maintains the anterior chamber, whilst the vitrectomy cutter, introduced from the left side, aspirates the cortex from the right half of the eye. After which, a viscofluid exchange is performed, the hands swapped over, and then the cortex on the left half is also similarly removed. Following the completion of the cortex wash, a viscofluid exchange is now performed once more. And here's what we are left with. There is a central opening in the posterior capsule with 3 radial tears at 3 different parts of this opening. Now, we do know that any radial tear in the posterior capsule has a potential to extend. So in order to make this opening stable, with the help of an intraocular forceps introduced at 3 different points, these radial tears are converted into a stable round opening, and finally you're left with the stable localized opening in the posterior capsule. Being a stable localized opening, I'm now going to proceed to implant a single piece monofocal IOL within the capsular bag. As you can see, the lens is first introduced into the anterior chamber, and then its haptic is nudged deep to the anterior capsular edge and above the opening in the posterior capsule, thereby resulting in a successful implantation, first, as you can see, of the haptic on the right side within the capsular bag, after which viscoelastic is then introduced into the anterior chamber once more, and the trailing haptic is now also introduced within the capsular bag. The end result is the stable implantation of a single piece monofocal IOL within the capsular bag. Whilst maintaining the irrigation in the anterior chamber, the vitrectomy cutter is introduced just posterior to the lens in the IA cut mode to aspirate the excessive viscoelastic. Having completed that, the excessive viscoelastic is then gently removed from the anterior chamber. Now, having completed the visco wash from the anterior chamber whilst maintaining the irrigation still in the eye, the left paracentesis and the main incision are hydrated, after which the irrigation is removed from the eye and the right paracentesis hydrated. This, as you can see, is the end result that we've achieved. A quick check introduction of triamcinolone in the anterior chamber is performed to rule out any strands of vitreous that might have prolapsed into the anterior chamber, and should one find them, they need to be cut using the anterior vitrectomy. This now brings us to the end of this interesting surgical case of a posterior polar cataract that developed an intraoperative PCR during a hydrodelineation. I do hope you found this video tutorial useful. Thank you.